Pharm So Hard, the employees wanna find me and then wanna hire me. What's 100K to a guy like me? Could you please remind me? Pharm So Hard, this ain't easy. Working late nights, you best believe me. My grades can only go ace. Never wanna see another B unless I'm Jay-Z.
All right, guys, so let's transition to something that's a little bit more clinical and a requested topic, and something I knew it would happen, but happened to me yesterday in the evening. I was like, oh, I have a patient with Afib and RPR, but he has heart failure. Jimmy, what do we do? And I said, you guys just like hold on about a day or so, and I'll make sure I have everything important for you to know what we're doing. But before we dive a little too deep, just for our classical patients or non-heart failure patient with Afib, talk to me, guys, about the ages that you commonly either see, or if you had to recommend one, just one, what would it be?
Well, I'll say that the whole mantra goes, ED, emergency medicine physicians like Pilsheisen, cardiologists like Pilsheisen.
Hey, it's like that up north too.
It's all like that everywhere. I'd be really curious if anybody's watching or if you know this from the podcast, think about that and leave a comment on wherever you are on the podcast. Is that the case at your shop, right? So, and I theorize on some reasons behind that, right? Heart failure side and all that, right? Till law, and I think there's some decent evidence showing that TIL works quick. It works pretty well if you dose it right. But and probably over metoprolol. But the question I try to remind a lot of our residents, a lot of our physicians, like, what's the issue going to be on a year from now?
Yeah.
Right? They're more likely going to have some compelling indication that it requires a beta blocker. And so I think that's cardiology's angle with starting with metoprolol. Let's just make it seamless and let's go from here with metoprolol. So that's kind of my initial piece on Phil.
Yeah, I think I don't know. I'm probably team rate control. So whether it's metoprolol or Pilsheisen, that's probably my general go-to when they're asking me for recommendations for how are we going to treat this.
Yeah, I'd agree. I'd probably throw a curse word in there and just say, what the hell are they going to be on later on? Like, what can we get them to take? I think you're right. They probably have a fair amount of compelling indications for a beta blocker, but you also, if you don't have to use a beta blocker, it has probably more side effects than a calcium channel blocker. I mean, around here, exercise intolerance is a big issue, right? Potential ED, things like that. So sit down, talk to the patient about pros and cons of each if you have the option, and then see what's going to fit their life better.
This is my PCR research project.
Jordan.
I think those hydrogen. I think that there's more negative scientific effects of the protocol, which if you're worried about throwing someone into acute complicated heart failure, concern number one. And then there was that study that showed that the hydrogen was just as good as the protocol for rate control. And my study was safety. Oh god. My study of safety was no difference with those hydrogen compared to like alternative therapy. I would say it was a protocol.
All right, man. So what doses are you talking about with Pilsheisen being like better than?
I think people back off on tilt too much. They get nervous. Like if you're gonna go with tilt, go with the tilt. Don't pretend. You get 100 dose. Like, yeah.
And you're right, dose. Tony brought that. It's like serving up. It's all about the dose, right? And so if you're going to do Pilsheisen, it is a little bold. You got to make sure you have the right patient. They're not already borderline hypertensive, but 0.25 mg per kg, right? That's the dose. That's the FDA labeled dose for given tilt. And if that doesn't work, guess what the repeat dose is? 0.35 mg per kg. And then with the tilt too, I don't know if we know the right dose as well, but it's there, and it's like, okay, 5 milligrams every 5 minutes, times 3 doses, 15 milligrams. But I don't know. That might jump ahead, like if I were to be able to do a study, it might be kind of more like those studies. These ages.
Yeah. So I guess I'll put my hand for it. For people who come in acutely, who I don't expect to go home on it for long work. My general thought is, I ask, where to get admitted? If they're going to get admitted to the floor to medicine, and they're not going to they're going to have a cardiology consult and they're just going to follow along, I'm more so on the guilt component versus if they think something is wrong and they're going to have like an EP, get involved and have parts come along, I'm going to be a little bit more conservative and go with metoprolol. I will say, anecdotally, in my very short career, acutely, it works a little bit more favorable for me. And I will say that early in my career, I played around with the 10 milligram dose. I didn't get too far with that. And I started using bigger doses, and I was like, oh, okay, this works. But I would argue for me, in all AFib patients, that for the patient that's going to break, I can break them. I think the most important part is like that hour right after I break them. Because I think once we get them situated, nothing happens for hours, and they go back into it. And I think I can change this dose, and I can change a few different things if I can get them under control, and then get whoever's going to take the patient initially and get a second dose of something on board if you. Yeah.
And I think that's a big trend that I'm starting to see, whether it's on blogs or in top down from attendings, is to go ahead, and we teach it too sometimes, go ahead and start that PO dose or DIL, wherever you started IFB. Right when you get that second dose of IFB, let's go ahead and start that agent PO. Especially if they're we're talking about simple or more simple, less complex AFib, and they're looking like they might get discharged. And that is let's get them on the DIL 3 times a day, and we'll go all 3 times a day, and start that PO dose when we're giving IV and maybe some fluids.
Andy, what do you want us to do down in the ED when they come up to you?
You're rounding in the daytime. It's like,
damn it, Lamb.
We're studying this. We're studying it because we're doing it a lot. We should be doing a lot. So we're really nice about that.
It's really funny. And we were kind of talking earlier is the utility of diltiazem in infusion. I feel like certainly over the last couple of years or so, I've just seen a lot less of them, and maybe we're just more effectively giving better doses in the ED, and that's actually breaking patients in the ED, and they don't then have to be on infusion after that. But I don't know. I guess my answer to that question is whatever harms the patient the least is probably the right drug to pick. Fair.
And I was asking Tony before we said that. I was like, how often do you see DIL drifts up in the area? Not a whole lot anymore, right?
Not a whole lot, no. Diminishing.
We certainly don't see them. We don't initiate them near as much as we used to. And probably 5 years ago, 8 years ago, when I was in Texas, all the time, DIL drifts. And getting a look, and this is what we talk about maybe a little later with some of the other drugs and stuff, and calcium channel blockers and indications. This is one of those stories that if you dig, it's like, well, what's the evidence behind diltiazem infusions? Well, there's not really a lot. If you get back down to like package insert even says don't have somebody on a DIL drip for more than 24 hours. It's never been studied. and then you go look in the literature, really isn't in the literature for anybody on the DIL drip longer than 24 hours. So that might have something to do with the kind of the deprescribing of the DIL drips. There's been some other fan of Brian Hayes had a good post on his blog about DIL drifts and accumulation and kinetics of DIL, and probably like things like labetalol and football, really. Also labetalol and DIL, but we don't really have a great grip on the kinetics of it and the potential for accumulation and such. So which I think certainly happens with this.
Yeah. So let's segue. So the traditional patient, I think we're okay with. Where I see people get a little more upset is when a patient comes in with a history of heart failure, and again, most of the time now we can throw a probe on them to go, oh yeah, that's an OEF. So I know, and my colleagues know that I know that it had low EF, and I proceeded to give them DIL, and immediately when I verify the order, It's just a mess sets off their air compartment. They're pissed. Because the patient has heart failure. You should never give a patient with heart failure a calcium channel blocker. So that's the second instance. So what are the considerations that must be taken into account when managing patients with heart failure? I think it's deeper than just a number on injection pressure. It's deeper than that. So what are the things from the experts you guys help us understand?
I think the first thing that comes to my mind is, are they in decompensated heart failure, right? Are they in cardiogenic shock? If they are, I'm probably going to steer clear of, really any negative inotropic agents, including, diltiazem or even, beta blockers in themselves. Just going to generally avoid those things.
Yeah, totally. It's kind of like avoid all of them. What's the difference in the negative inotropic effect of TIL versus metoprolol? Nothing. They're the same. They're the same, right? So, they both ultimately work on calcium channels, right? And so it's the same inotropic effect. So where we get that is that we know that calcium channel blockers are bad for patients long-term in heart failure. Mm-hmm. And the questions there, that question and the studies that support that are probably questionable, at best. Also, beta blockers have so much awesome evidence. Now we're talking AMCARE, right? Outpatients. So we don't want to talk. We're easy pharmacists. But the beta blockers are still, some of the best evidence for inhibiting cardiac remodeling and being great for heart failure patients. But back to like
I know those words.
Yeah, right. But back to what do you do about heart failure patients? Heart failure does store enrichment cues. It creates is a fascinating problem to me in ED. And Megan and I had a case the other day, and we sat and talked about it. If this happened, what happened? Is this the right choice? Is that the right choice? And I don't know, really what we did. I don't know if it ended up being a good choice, but this was a acute decompensated patient who also had AFib. Okay, acute decompensated heart failure and AFib. It's a bit of a chicken and the egg phenomenon. Which came first, right? Is their AFib so bad, and maybe the AFib's at a high rate, and that's what's causing their kind of pre-existing heart failure? But a lot of the times, I'd say the majority of the times, they're fluid overloaded. It's that same cascade that causes SCAE, pulmonary edema, crashing patients, is that they're pulmonary edema, they're edema, and all this stuff. They're fluid overloaded, and that's exacerbating their AFib. Their AFib's going fast, RVR, and it's hard, and their decompensation is even worse now. So I think the key is that this is not our pharmacist forte, is the physical exam, right? And that's why I try to plug it up with our residents, our attendings, the physician, and to get with them in real time, talk about the imaging, the chest X-ray, or the fluid overloaded, or the lungs sound red, the edema, and to talk through that with them, especially our residents, our physician residents, learners, and say, what do you think? They super vet, they decompensated heart failure, and then that might be kind of where we start. The AFib might be just a symptom of that.
Yeah, I think that's right. Good supportive care in the management of their heart failure may preclude you to hopefully just do nothing, and then they just kind of get out of it, right? Yeah.
One of the things I like to do, and I get picked on quite a bit. A lot of the pharmacy residents, they ask me, like, are you going to go do the ultrasound yourself? There must be questions you might ask. I go to the bedside, I'm checking to see if I'm putting edema. The one thing is, if I can do it, I'm not hurting the patient. I'm gathering data. Before I come to my physician and ask me to do something, I want to say, based off X, Y, Z that I was able to do, this is what I'm thinking. Can you do an echo for me real quick? Can you do X, Y, Z for me and then not do anything? I think now in my career, I'm a lot more to gather more data first. Is the patient dying? Yes, no. I call it, it's my podcast, like I said, I call it my oh shit kit. When I walk in, is the patient so messed up I have to do something now? If not, gather more data. Because if you're not failing my oh shit kit, I want to figure out what else can I do. And these are the patients I'm looking at in great detail. I want to make sure that I'm headed in the right direction.
Yeah, and I think not being scared of the physical exam, not being able to do it yourself, but not being scared of it, because I know it's intimidating, but knowing the language to talk and the words to ask, or their rails or their faculties, that's what you don't have to get too much into that. You say, hey, doctor, lungs sound wet, or you throw an ultrasound on an IVC. But the only thing about those two, that helps you engage with the provider taking care of the patient and worrying about the AFib too. It gets you a little deeper into that and give you some more knowledge. But I will tell you, the last student I asked to put on a pair of gloves and check for kidney edema, she got out of the room. I haven't seen her since. No, it's so being able to not being scared to touch the patient in a respectful way, want to be able to check for kidney edema or seeing an IVC.
Yeah, I think it's part of what's special about emergency medicine is we are at the bedside so much that we can be, some of the first pharmacists to start to really incorporate this. Again, not doing that physical exam, but being there to see it. If it has something to do with pharmacologic recommendations, we should be there. We should know what it means because it helps us make the best recommendations, and that's what we do.
And I think the coolest thing that ever happened to me, I had a patient that was compensated. I walked in, and then the person who was the chair of the department presented the patient to me, handed me the EKG, and said, what do we do now? And I was like, great. So I felt privileged at that point. I was like, okay, this is a big time shot. But the reason why I took a month rotation acting as an M4, as a medical student, seeing patients doing these different things, so I can understand the physical exam, I can understand the basic things. And now, when I come and I make my recommendation, they know I've looked at these things too. So I think from a pharmacy standpoint, a lot of times I hear people say, and I call them lexicon pharmacists, but I hear them say, stay in your lane. Well, anything regarding medication is my lane, and any information that leads to that. My thing is what's the difference between an ultrasound and then a bank level? A bank level lets you know what you can do to make your medication. Again, an ultrasound helps you understand what you can do to make your recommendation for the medication. The physical exam helps you understand what you do to make your recommendation. So now I have that conversation. I figure what's going on. I do the best I can. And I think that's something we probably should look at instead of doing 7 PQEs, maybe doing 1 month of physical exams. Maybe I have to still list if anyone wants it for my physician assistant.
Actually, and I said earlier, you ask the physician who's also working out the patient, using certain words and certain language, hey, does this look like this? Does that look like that? Or there's some inverse ways on the EKG. Okay. And it builds your credibility a little bit too, right? As a pharmacist, as a clinician, not just pharmacist as a lecturer. Right? So not going overboard, but pitching into that because those are pieces of information that we need. That we need to treat the patient. So heart failure is a great example. It's just those exam findings that need to go.
All right, guys. So all of this has me wondering, just from my cards bros here, what are the pharmacologic agents that are preferred or contraindicated in patients with AFib and RVR with concomitant heart failure? If we had to put you between a rock and a hard place, how do you answer that question?
Well, with heart failure, AFib with heart failure, I would say that diltiazem's not an absolute contraindication, right? Diltiazem I think it got a bad rap back in the 90s, just like all other drugs did. There was a diltiazem study in 1991 that was studied in post-myocardial infarction patients. Started 5 days after and continued, and patients were followed up for 5 years or so. And diltiazem in the patients that had a lower EF, diltiazem ended up being worse, right, versus placebo. And so diltiazem kind of had a bit of a bad rap. Verapamil had a stronger enotropic effect. It's used a lot more back in the 90s. Then comes, it's kind of an interesting timing thing, right? Right then becomes in the late 90s and 2000s, all these beta blocker trials came out for heart failure, the Merit trial, the Med trial, and all these. It showed like, gosh, there's so much of a survival benefit for beta blockers. And so I think the combination of two things just kind of gave Tilt, a bad rap. And the other calcium channel blockers, right, the dihydropyridines, some peripheral edema. Maybe Tilt does too, right? So that can be good for heart failure. So, what was your question again? Talking about Afib and heart failure. Okay, which one would I use?
What's preferred? What's contraindicated?
Again,
All right.
It's what patients can go home on. And I think that really kind of guides you, like, all right, they have heart failure, they have a compelling indication, or they're already on a beta blocker. So I think what the patients can go home on.
Yeah, this is a simple yet complicated question because I think, it all depends on the sort of the clinical scenario and condition that's going on. So, if they're in cardiogenic shock, like I'm going to be hard pressed. Anybody's going to be like, yeah, definitely give them that giant bolus of diltiazem. And so, what are you left with? You're left with mostly anti-arrhythmic drugs, right?
Mm-hmm.
And which one of those anti-arrhythmic drugs? Well, I don't know. I can tell you this: I don't think I've ever recommended Multac or dronedarone on any patient. So I'm pretty sure I would never use that in somebody with really bad heart failure. Probably same goes with other antiarrhythmics, mostly probably class 1 antiarrhythmics. I'm not going to give that person flecainide or something like that, just because they're probably at higher risk for just arrhythmia in general. And the last thing you want is you gave them a dose of flecainide and now they're in torsades and now you're doing a bunch of other stuff beyond that. So yeah, exactly.
And so many of those drugs, I think, likewise, the flecainide, Afib, they got black warnings, they got bad raps, nice trials that showed that they were apparent mortality and structural heart disease. Okay, so the elephant in the room is DIDGE and amiodarone. Right?
Yeah, absolutely.
Oh my God! Do you want to be shot with a gun or stabbed with a knife? They're both not great agents, and for several reasons, right? But we get the DIDGE. DIDGE could be a great drug in that scenario. It's got actually positive inotropic effects, negative chronotropic effects, right? So it's kind of that ideal drug. It has no other mechanism like it. And then amiodarone. Well, they're both slow. Both have bolus, both of them. And they both don't work very fast. And we whatever we're trying to do in this scenario, we're trying to kind of do it quickly. And talk about being committed to a drug. You certainly put yourself here. You're throwing around DIDGE, you're throwing around amiodarone.
I sit, again, this happens so often, and I sit there, and I'm eating, and I have cars with me, and I usually it's NICU or MSICU there as well, my ED team, and we're sitting there going back and forth about how many boluses of amio should I get? Well, just keep it at one turn it to 2 milligrams per minute. Let's do something. Do lidocaine. I'm like, we're treating AFib. Okay, well, we're flexible, okay. But I'm always confused, and nothing works for me. Anecdotally, in my short career, I've seen DIDGE work in those patients that were older, that, again, it had AFib, RVR in the 120s. These wasn't the ones that was hypotensive, 140s, 150s, and we're just doing bad off. Amio, I think people like amio because it works half the time for everything. That's the only way I can think of it. It works half the time for everything. It is the Vancomycin.
Yeah, amiodarone is a funny history associated with it, right? Because it's one of these quote grandfathered drugs in. So it's you look at the real indications and they're for life-threatening ventricular rhythm. Everything else is off-label, and you're like, oh, okay, that's a weird indication. Well, let's use it for AFib in this person, right?
Absolutely.
It's not to say it's not without risk either. I know people are familiar with amiodarone and they're comfortable with it, probably just sheer numbers of prescribing habits, but it's not to say that bad things can't happen with it either, right? So like, one of the questions that we often ask ourselves is like, how long have they been in AFib? If the answer is we don't know, but we think it might be a long time, and you give them amio and then they convert and then you throw a giant clot and you make them stroke out, like that's bad on you, right? So, I think there's just lots of consideration thinking about, what's the optimal agent to give these patients who are in AFib with RVF.
And I think that's where I tell my residents at this point, we learn in pharmacy a lot of black and white in a gray world. And board certification, NAPLEX, all these things push us to have one right answer. And I've never gave the same dose agent for these patients that come in. They look exactly the same, and depending on who I'm consulting, I sit back and I say, what's going to make you and the patient feel better? Because realistically, I don't feel strong about anything that we're doing right now. As long as the patient's not acutely dying in front of me, what do you want to do? I've heard everything. I've heard Concomitant, I've heard amio, I've heard DISH, and we've also just given them Delta. We've also just given them Topol 5 times 3, and it didn't work. And they said, just give them 10 one time and see what happens.
Yeah, I think you nailed it there. It's like, think about things, sit down, and invariably you'll get real theoretical about this stuff. Because you go, oh, well, their EF is probably high. Oh, we're going to fight afterload, you have pressors. Oh, what's their pulmonary artery pressure? Oh my God, what if are they going to put swans in them upstairs? And you start getting into this, and you start messing with your mind, and you get messed up. And so I think kind of getting to that limit of thinking about all those things, to kind of reel yourself back in, and as Andy mentioned, supportive care, right? And going slow and low with these patients. And Dave, my resident, I had one the other day. It's a perfect example. There's a huge heart, decompensated AFib, decompensated heart failure, and they were AFib too. And I walked out to I told them, start some low dose pressors. Could have done dopamine. I don't know. What do you think? Could have done dopamine. Low dose pressors. I'd increase your afterload, and it might affect their heart more. But this is, so we kind of go through that, and sure enough, we gave them, because they were hypotensive, and we gave them just enough pressure support that it kind of helped maybe build a diastolic pressure. Here we go, getting into theoretics again, but the patient's kind of heart rate slowed down. They got a little bit of fluids, but kind of slow and low supportive care, I think, was the right answer there, and it's always the right answer.
I just pause immediately when I get these patients, and basically again, they fail my oh shit kit, and if they're not above 65. I just thought, I don't need to do anything right now immediately. And I think one of the challenging things from a pharmacist standpoint, especially again, we're all working at academic centers, is your medical resident is going to do something. And I say call cards. That's the first thing we should do. But what should we do in between then? We can wait for a second, get the patient volume down, give them like a 250 fluid bolus, see what happens. I literally just drag them along and just make them do nothing. Oh, this other patient over here, and ask a bunch of questions, and then guards all back and I thought, what do you guys want to do? Because what's going to happen is whatever we do, they have to continue it if it's a real AFib heart failure patient, because it's not I don't think of it as a one-time event. This is something that's going to be, it's one of the phenomena that's literally 3 different phases of care in one. It's literally an ED, ICU, and ambulatory care patient all in one. And whatever you do now is going to change moving forward. If you DISH, you have levels involved. You have all these different things you can get involved with. If you DISH, what loading dose do you use? Do you break it up into every 6 hours? You get it this 0.5 all at once. What do you do? So I try my best to not act if I don't have to. I don't itch when I don't scratch when I'm not itching. That's what I think about. I don't do it if you don't have to.
Absolutely.
And I'm going to put this in the show notes if I can, Jimmy, but there's one study I was going to mention, which is one of my favorites. It's Schweremeyer and some nursing medicine back in 2015. It's a couple Canadian, multi-center Canadian hospital. They got to where they had about 400 patients. And then, it's retrospective. They looked at about 200 patients, they didn't do anything. These were heart failure patients with AFib. 200 patients, they didn't do anything. Some of them got up to a liter of pistol weight. The other 200 patients got rate control. Some of them got rhythm control. There was about somewhere like an 8 to 12 times higher risk of adverse effect from the patients that got rate or rhythm control. And one of the surrogate outcomes was like, with that heart rates coming like down by 20 within 4 hours, and actually the liter of pistol weight fluid achieved that more often. Right? It is fantastic. It's an interesting study, it's retrospective, but it looked at like doing nothing, giving a little fluids, versus doing something. And sometimes we try so hard to fix the numbers. Sometimes we run under pressure. Well, patients can have to go to the ICU unless we get the heart rate below 120. So we try to get the heart rate below 120, sometimes below 100. We end up harming the patient. And it's real harm, But the ED is busy. We got to get these patients out of here. We can't get them to the ICU, or there's no ICU beds, or we got to get them the floor. Mid-floor won't take them if the heart rate's high. And they're batting over this pressure.
That's when Andy looks at us and says, ED needs to research this is interesting.
You're getting a peek into our minds.
Right.
I have a question for you guys. Magnesium works for everything. Anybody sprinkling magnesium in there for these patients?
Shout out to our boy here. Y'all boy, he does this for every single thing.
Does he?
He's on ketamine, he's a Mac.
I'm going to call out if you see a man, a pharmacist named Hugo Coaston. He is I haven't heard from him in months. He was my resident last year. He owes me a paper on magnesium and Afib. We looked at that last year. We're actually kind of compiling the data together. Hopefully, we'll publish it soon. We just retrospectively did a couple grams of mag in AFib patients. But certainly, there's some compelling data on mag being non-harmful and perhaps beneficial intervention. Maybe 4 grams.
So much.
Yeah, there you go.
That's the thing. It's like
4 grams.
one of my staff pharmacists want to try to pimp me. It's like, there are people get 9 grams of mag. And they have a low mag level. You shouldn't give mag. What's going to happen if I do give mag? Nothing. Yeah. So, intriguing. You answered some of the other questions because I wanted to really drive home the mechanism of action of the calcium channel blockers. Same as the beta blockers. They're both going to cause you to have, in a patient that's in decompensated heart failure, to worsen. So I never understood it until I started looking, and then the more I got into podcasts, the more I got into like looking up this stuff, and I was like, wait a second. We're just saying this because of one paper, and we're doing it from like an outpatient. We're trying to apply that same data to our inpatient, acutely ill patient, and it doesn't work out that way. Is everyone watching and listening? It's like, it's deeper than that. Everything we do is deeper than that. And I think I started asking more simpler questions. People were like, oh yeah, I know. That's simple. It's like, are you sure? And then you start to ask yourself, really.
We learn these rules, and those rules help us early on in training and trying to get put things in a box. You'll get beta blockers to people with asthma.
Yeah.
You'll get calcium channel blockers to people with heart failure. And it helps us to kind of create some rules when we're learning, right? But you start learning more about it, learn it well. Why do those rules exist? Why is that in the textbook? Right? And then there's some pretty funny reasons for that. Yep. Sometimes no reasons at all.
Okay.
Period.
Any questions before we start to summarize all of tonight?
This is more a question to like the panel of experts, and this is kind of referencing back to the case that Lance talked about already. But in the patient who has AFib RVR with acute decompensated heart failure, you tell which one is calcium channel. Which one do you treat? Which one do you think is the cause? And I don't know. How do you do that?
Yeah, I think sometimes you don't know, right? And so you just do it all, right? You do excellent supportive care with regard to their heart failure. And if they're still hemodynamically unstable, you do all the things to, slow their rate down or potentially convert them.
I think one thing that I look at is you got to do a little bit of something that's source one and see what happens. The patient comes in and say you're writing down. Say they're not fluid overloaded. Say if you're not. and they have again, a non-experienced patient. We're not speaking completely database here, but if I can check an IVC and it's like fully collapsible, I said, hey, can I give 250 of fluids? And what happens? I don't have an A line. I'm checking my blood pressure. Again, I'm not being very evidence-based. But if I get some response, if my mental status get a little better, my blood pressure get a little better, I'm thinking, okay, maybe this is something we can go that route. If I'm just my patient, she's like just cracking away with the ultrasound program. I ask for ultrasound every day. My residents laugh at me quite a bit, but my medical residents laugh at me. It's like, let me guess. You want ultrasound? I'll just put it right here and see, because again, it's just, I want to figure out what's the real issue. But I think if you dig deeper, and I'm doing passive, I'm physically doing passive leg raises, I'm doing everything I possibly can to figure out at a micro level, can I get a marginal improvement in one thing versus the other before we go there? The one thing we haven't mentioned today is like Esmolol. Esmolol is one of the things that we, turn on for 10 minutes. See what happens.
I was just going to mention that. Esmolol is kind of a final word, final drug. We haven't talked about today. Tough thing about Esmolol is it is an infusion, but that's why it's an infusion. It's just a half-life, so short. And that's why I think it does have a place in these patients we're talking about. That's the beta blocker, that's the AV nodal blocking agent I would pick in these tough patients if I'm gonna go down that road, right? You just turn it on, you turn it off, and it's gone within 10 minutes.
Yep. My thing is I turn it on 10 minutes, get an ultrasound beforehand, so I get an ultrasound 10 minutes after. I work with my residents. I work with my residents, right? So you can see what it looks like before and after. If my patient looks a little more shocky after, okay, if they look really bad, then my physician is like, hey, this looks really bad. Like, hey, can we get a repeat? Like, say, can we get a repeat of these things again? Not very evidence-based. I'm going to put it out there. This is not very evidence-based. But it gets to be at least one picture that can say whether my patient is looking better or worse after I get one thing versus me giving that fluid bolus to that passive leg raise to see what happens. And then from there, we saw our cards colleagues kind of weigh in, and then we can get a happy medium. But I'm not gonna lie, I try to play a little bit before I call them, or I make them eat as a call and then get them to work. So that by the time the cards resident come down, 10, 15 minutes later, we did these things, and then they can now give this information over to the team, and now we have a more complete picture. And we can go from there. And then my thing is like, don't do anything. The best recommendation I've ever gave was to do nothing.
That's great. And that's what I was emphasizing with some of that literature. Is sometimes doing nothing, and if we do something, go low as well. But to recap real quick on I guess this patient with heart failure, decompensated heart failure and AFib, try to glean something from that physical exam. Okay, their heart's large, they've got pulmonary edema, they're wet, they've got pitting edema, then it might be more of a heart failure causing a kind of a crashing pulmonary edema, which is driving AFib. On the flip side, if maybe you don't find those wet lungs and that pitting edema, maybe it's not a lot of it, maybe if their heart rate is in that like 150 to 180 point, that's certainly going to lower some cardiac output, right? So also then kind of back up and, okay, maybe they're not in a usually decompensated heart failure. And another thing to keep in mind is people with heart failure on their profile, or it just gets tagged on there like, yes, maybe they have heart failure. Maybe it's with preserved ejection fraction. Maybe it's with reduced ejection fraction. You just got to put it on there, and they don't really have it. It's like an early form, and there's no reduced ejection fraction. But backing up, okay, maybe they don't have a lot of exam findings suggestive of fluid overload. And then back up and look at the actual heart rate, the RVR rate of this irregular AFib. If it's not 100 to 130 range, I don't know, maybe certainly don't do a lot. If it's in that like 150 to 180 range, that's some pretty rocking AFib that really might be perpetuating some heart failure, some reduced cardiac output.
Yeah. And I think, one thing that we kind of haven't talked about globally is like, if you're an institution that has EP, catheter ablation has really just sort of fundamentally changed the game of AFib and heart failure over the last decade or so. And so, those are options now that we can offer to patients and say, okay, we're going to refer you to, our EP colleagues, and, maybe they can do a procedure where, this blunts this from happening in the future.
Yeah, I just think overall, just taking all the information. I think all pharmacists are also right. I think if you're in the ED, if you have the capability, even if you're in the unit, again, I remember I was in the unit, I would go and do pre-rounds, I'm doing drip rounds, I'm doing different things, and I will usually grab a med student or like an intern and bring them with me and say, grab your tools with you early on. And what patients do you have? I will see those patients with them. They would do their physical exam, they do their things, so they would get amped on rounds. And I'll make them do all the stuff that I, as a pharmacist, should never do. It asks them questions, and really you can find a way to get as much information as possible. So when it comes time to make a decision, you're not making a decision based off of what's the compromise terms, Oh, I saw battle time XYZ, I saw a history of this, and I recommend this. It's more so based off of all of this data. This is what we should do. And if this doesn't work, these are my 3 other recommendations. And I don't want to, and these are the patients that if I use something like Phil, this is the only time I would want to use 10 milligrams. I want to do a little bit of one thing, see what happens. Do a little bit of fluid, see what happens. And again, people can completely disagree with me when it comes to that, but I try my best to, I gather more data and I give less meds. That's kind of my overall in these very, I had to turn back for me. And I remember, we all remember the back cases. So that's great.
That's great advice as a learner, I think. Yeah. Fair enough from that student. Maybe each other with good amounts.
Yeah. They are intrigued. So again, any questions from us before we close out? It's been super dope. Like I always want to figure out ways that I can find a way to get people who are much smarter than me to come talk about things that I think I know a little bit about, they know a lot about. So super intriguing. Thank you guys for, if you guys are watching abroad. I know we have people that I'll get earlier from Australia. We have people from all over. So super excited for all you guys to join us in another episode of Pharm So Hard. Any closing words for you guys for this whole experience?
Oh, gosh, thanks for having us, Jimmy. Thanks for coming into town and letting us sort of be your guest and host you, the host. This has been fantastic so far. I got to get you a quick tour of Denver Health earlier today. And so we really appreciate you coming in. And I think I can speak for everybody here with just the thing that you're doing and just getting out, getting people talking, getting people connected and networking, and talking about different types of practices. And that's just huge, especially things like burnout and provider status and stuff that pharmacists are working really hard on. So I appreciate you for doing that.
Yeah, thanks for coming by again. I think, what you're doing here is fantastic for, the pharmacy community and for learners especially. And, it's great to be able to participate, in a forum like this. That's so chill.
Mm-hmm. Yeah, exactly. First of all, thanks for being here. We're going to show you a good time tomorrow. But I feel like I've always dreamed of a podcast where we don't sound like robots. We're not reading. This is how people talk when we practice. And I've always wanted that. So it's really exciting to be a part of that. I'm glad you're doing it. I know what came out of Empower was we want our own space, and you're the one building it. So thanks for doing that. Thanks for being here, and let's have some fun tomorrow.
It's super dope. This is I was the kid who was in the project growing up. I was the kid who was doing, less than the things that your patients come in doing. They tell you, like, whoa. That's me, but I think it's really unique that I've been embraced in this community, and I've never been to Denver. I've been to the West Coast, like 2 times before this, only for pharmacy. So I think it's cool that we can build a space where we can be ourselves. And that's really what it comes down to, creating a platform we can really be ourselves. I don't know any other pharmacy platform where they're sitting up here drinking beers. So that's dope. So I'm going to close out the same way I close out every single episode.
Real quick, before you do your thing, we want to present you with, we got something for you, honorary Denver Health t-shirt and water bottle here. So we want to send you away with these. I know Denver Health speak and Tony's heart too. So these are from us to you. So cheers.
Thank you guys. Thank you. And of course, you guys probably have some in the know. So we should go from there. Thank the audience. Thank everyone for being here. And of course, you don't have to be a pharmacist. You're not working in ED, whatever you do, make sure you Pharm So Hard.